In the trenches, I'm David A. Cohen. Today we're talking about acute pancreatitis. That was the recommendation of my medical student, Scott. Acute pancreatitis, it's something that we see in the hospital, and you have to be able to recognize it. Okay, so this is how I want to go through this. The symptoms, making the diagnosis, the causes, classification, and treatment. I'm going to attempt to do this in 10 minutes. So, symptoms. Patients usually come in, they're pretty sick, sometimes not. They have epigastric pain, they have vomiting. Really, it's epigastric pain and vomiting, unless they could have SIRS symptoms, they could be very sick. But usually, it's sometimes some type of abdominal pain. And basically, the way you diagnose it, you get labs, a lipase, you have classic symptoms, and you have imaging. Now here's the bugaboo here. You need 2 out of 3 of these. So if you have a patient who's got abdominal pain, okay, and they're vomiting, and say they have a history of alcohol abuse or gallstones, and you don't need a CAT scan, okay? And if you give somebody the CAT scan and you have to give them it with contrast, you run the risk of acute renal failure, acute kidney injury. Okay, now most people who come in are going to get this, but it's not necessary. The causes, 70% are alcohol-related or gallstones. And, this you're going to have to get by the history, and you're going to have to figure that out. But there are certainly other things to think about. Metabolic, hypertriglyceridemia, medications. Most common med is azathioprine, but you can see it with Depakote, valproic acid. That is valproic acid, I'm sorry. Pentamidine, not used too much anymore. L-asparaginase, which is a chemo agent. And there's a whole list of medicines, including ACE inhibitors and statins. And you could also see it with checkpoint inhibitors now. Okay, you can see it post-ERCP. So you have a patient and an ERCP, and then they develop these symptoms. You could think of that. And really to prevent that, you give a non-steroidal suppository prior to doing the ERCP. You can see with trauma, you can see it post-op. Theoretically, you can see it with hypercalcemia. You can see it with the IgG4 related disease, which could also be a chronic pancreatitis. Theoretically, you could see it with cystic fibrosis. That's in the idiopathic cystic CTFR gene, or SPINK1. Okay, the other thing you could see with, they don't have gallstones, but they just have sludge. They just have sludge there, and these people need a cholecystectomy. If you really want to be esoteric, you think of black widow spider bite. And you could have pancreatic duct abnormalities, such as intraductal mucinous neoplasia and these other things. And if you can't find the cause of this, you're going to have to do an MRCP, possibly RCP, to look for intricate lesions in the pancreas. Okay, now how do you classify it? Okay, and how do you treat it? So the bad thing here is necrotizing pancreatitis. These people do worse. You can have interstitial and necrotizing. necrotizing would be the CAT scan you would do here, and it would show filling defects in the pancreas. It would show evidence of necrosis. But before that, you get something called SIRS, okay? Tachycardia, fever, leukocytosis. And these people are really sick. You go from SIRS, necrotizing pancreatitis. The late complications, which could occur 6 weeks and beyond, are pseudocysts, and phlegmons, etc., etc. But this is really what you have to think of. Now, as far as severity, there's this classic teaching called the ransom score. It's not really used much now. And then a different one from alcohol and from gallstones. And classically, we learned that the score associated with alcohol, which had a presentation and then 48 hours. I don't know if this is familiar or not. Presentation was glucose greater than 200, white count greater than 16,000, BUN increase greater than 5 from baseline, needing 6 liters of fluid or more, and drop in hematocrit 10%. 48 hours of low calcium. This is base deficit of greater than 4 also. Okay, low calcium, PO2 less than 60. I'm trying to think what else. This is my mistake here. The other things on here, this is whites have 16,000. I made a mistake here, excuse me. SGOT greater than 250. LDH greater than 350. Okay. And base deficit greater than 5. Here you have an increased BUN, decreased O2, decreased calcium, requiring 6 liters of fluid, or hematocrit decreasing 10%. And then you add them. 3 to 4, you had a 15% mortality, and 5 to 6, okay, you had a very high mortality. Now, this is historical. What you really need to know when you're treating acute pancreatitis acutely, especially in a sick patient, you're going to be giving them IV fluids, okay? And if the hematocrit does not decrease, and if the BUN does not decrease, it means you're third spacing fluids. These people do bad. So that's really the best prognostic indicator. Pouring fluids into them. This is more historical, and excuse me for not rattling that off. Now there's something called the BISAP criteria, which is S is SIRS, A is age, I think greater than 60, P is pleural effusion, I is impaired mental status, and B is increased BUN. Okay, but the major thing with that, initially you're going to worry about SIRS, okay, and you're going to worry about then developing necrotizing pancreatitis. And if you develop that, you're going to have to worry about the pancreas potentially being infectious. Okay, so what do you do now? You're evaluating somebody, and things have changed a little bit. Classically, you would pour fluids in. You would just pour fluids. And there's a recent study, I think it came out 2 years ago, called the waterfall study, which showed that people who don't get as much fluid do better than people who get tons of fluid. So you have to give them fluids, that's important, but you have to be a little more cautious. That's number one. Okay, number two, as they're getting better, it used to be you'd keep them at NPO. Early feeding is better because you get decreased transudation, okay, a bacteria from the GI tract and less sepsis. Okay, you want to look for the cause. Okay, so if it's alcohol, you might get that. You might get that via the history, and they might need a CWA protocol. Usually their transaminases are really high, so you want to look for gallstones. So with imaging, the CAT scan's the best thing to image the pancreas. So really, the ultrasound's the best thing to image the gallbladder, not the common bile duct. If they're gallstones, the patient needs their gallbladder removed, preferably while they're in the hospital. Okay, if their transaminase, if their liver chemistries are abnormal, they need an MRCP. And if there's a stone there, if the duct's dilated, they're probably going to need an ERCP. What you will do is a papillotomy. You put you get a hole in the ampulla vater, near the sphincter vitae. The stones will drain, and then you do a laparoscopic cholecystectomy. But gallstones need to be addressed while you're in the hospital. If you send somebody home with this, they have a higher incidence of relapse. Alcohol could often cause chronic pancreatitis or acute on chronic pancreatitis, and their lipase may not be that high. The other thing, looking for other causes. If somebody has triglyceride-induced pancreatitis, okay, you can die from that. And with that, often these people are placed on an insulin drip to decrease production of VLDL cholesterol, whether they're diabetic or not. And often they at least have glucose intolerance, and sometimes actually use heparin also for some reason. That works with triglyceride-induced pancreatitis. If you can't find the cause, you're going to be doing an MRCP to look for those small, cysts in the pancreas or something that cause obstruction. There are other things on the list. There's a condition called pancreatitis ductism, where the dorsal and ventral ducts of the pancreas don't fuse and it gets worse with alcohol. That's very unusual. Often if you don't find the cause, they need endoscopy, and you need to do it, aspirin, look for sludge. And if there's sludge there, then you do a cholecystectomy. But as these people, most of them get better, you're going to evaluate them for gallstones, you're going to feed them, and you're going to turn down the fluid. As far as some complications, hypocalcemia with severe acute pancreatitis, that you have to be on the lookout. Pulmonary, and that there's a debate on the cause, whether it's due to precipitation, due to the lipase release, causing calcification, precipitation, or due to low magnesium or abnormal PTH. That's not really clear. You could get acute renal failure, and that's why, due to hemodynamics, that's why you have to be careful with dye. Pulmonary, you could get ARDS. You could also get pleural effusions. The pleural effusions are on the left side with acute pancreatitis. And you could get atelectasis. Once in a while, you could get skin precipitation. You could get a paniculitis. It could really involve a lot of organ systems. Now most of these patients are stable, and you give them fluids and you feed them and you deal with their gallbladder, or get them to stop drinking, at least temporarily, and it calms down. And with that, I'm going to stop. Thank you.